Well, Nancy, I'm glad that you had a chance to meet Fiona. I am delighted to be here. This is one of my favorite cities. I'm a big fan of the food scene here, though obviously I ate too much the first night. I was pretty sick the first night. But I'm also grateful to have a chance to speak to this group, including survivors. I will show a few myself today, and I have a very special place in my heart for such individuals. I do have some financial conflicts. I consult for both Physio-Control and Zoll, which make mechanical devices, which I will speak to today. Well, these are the 5 topics I hope to cover with you over the next 50 or 45 minutes. The importance of early coronary angiography and angioplasty post-arrest, the utility of mechanical CPR for rescue PCI when cardiac arrest happens in the cath lab, a small little piece on left ventricular assist devices in the cath lab for those in cardiac arrest, hyperinvasive approach or eCPR for those in refractory, and then I want to finish with a few comments concerning the videos we saw last night that Vinay presented, and what it means when a young person, particularly an athlete, has sudden death, and whether they should go to the cath lab or not. Well, when I went to medical school, and it's been a few years, I was taught that there's a spectrum of coronary artery disease, and it starts with subclinical, develops or progresses to stable angina, unstable angina, non-Q wave or non-ST segment elevation in today's terminology, and culminates in an acute myocardial infarction, or as we say today, a STEMI, an ST elevation MI. But I've come to believe that is not the worst presentation for acute coronary syndromes today, but ventricular fibrillation is. And so these are 2 cardiograms done in someone's front room in Tucson, showing obviously the first a dramatic anterior STEMI. Moments later, the patient collapsed, was still hooked up to the 12-lead ECG, and the paramedics got the second one, which shows what I think is the more impressive presentation, ventricular fibrillation. Why is coronary angiography helpful? Well, I've outlined those reasons here. I think we live now in an era where we need to find the cause for adult cardiac arrest, and it's usually a culprit coronary artery. Once found, that culprit can be dealt with and flow restored, which clearly saves myocardium. From non-cardiac arrest STEMIs, we've learned that save enough myocardium and you will save additional lives. I'm hopeful, as indicated by the question marks, that we also can improve or decrease the risk of rearrest, and perhaps by improving myocardial hemodynamics, we can even preserve more brain function. Those are yet to be proven. But let's get started. Who should go to the cath lab post-arrest? Well, it's not a new issue. Here's a list of studies that included early coronary angiography starting in 1995. Perhaps the most important is the second on the list. Christian Spalding and his group in Paris, who had the largest series at that time. But notice at the bottom, even by 2009, there were over 1,000 patients, and the average survival was 60%. Of those who survived, 86% were neurologically intact. That's way better than what was going on when people did not go to the cath lab, where frankly it was about a 30% survival rate, and about 1/3 of those survivors were neurologically damaged. Well, what if you actually combine early cath with hypothermia? This is the second list I constructed from, you can see there's a little overlap. By 2007, some pioneers were cooling as well as cathing, but by 2010, almost no one reports a series of early cath without cooling. Look at the top, right? Now there's 4,500 patients in the series, and 60% survived, with 86% of the survivors neurologically intact. It's the same as if you didn't cool. Is that because cooling doesn't work? Not in my opinion. The first series contained a fair number of patients who were not cooled because they were already awake. Their prognosis is excellent. But if you're comatose, your prognosis is markedly reduced. These patients were all comatose, or they would not have been cooled. Hence, I believe, even though these numbers are the same, this series shows that you do actually even as well in a much sicker population when you combine those two therapies. Well, to date, at least when I made this slide, it changes almost weekly, there were 43 clinical cohort studies, 8,000 plus patients with a 62% survival rate and 89% of the survivors neurologically intact. That's a remarkable 60-90 club, if you will. And remember, the historical control is a 30% survival with 66% neurologic intact. Well, first and foremost, those who have STEMI should go to the cath lab, whether they had cardiac arrest or whether they did not. Even back in 2013, the American College of Cardiology plus the American Heart Association in their guidelines suggested this needs to be done, hence a class 1 recommendation with the evidence being moderate, or B. So their statement, as you can see there, it should be immediate angiography and PCI where a lesion is found for post-arrest patients showing ST elevation on their 12-lead ECG. And if you're going to do it, the guidelines suggest you do it immediately, not wait 2 or 3 days, in fact, not wait 6 hours till the 8 o'clock hour rolls around. This needs to be a commitment in the middle of the night, just as we currently do for any patient with STEMI without cardiac arrest. And frankly, you shouldn't wait for them to wake up and prove their neurologic status. That may take days, almost weeks in some cases. They need to go whether they're comatose or awake post-arrest. Well, what if you're brave enough to do that? What do you find? We took a series of about 750 patients in the US and looked at their post-resuscitation care and course. From that, we made this paper that we published about 2 years ago. Interestingly, only about a quarter of these patients had STEMI. 3/4 do not. They do not have ST elevation. Of those who had STEMI, 8 out of 10 have an easily identifiable culprit. And if a culprit is found, those with ST elevation post-arrest, 93% of the time that culprit is acutely occluded. Well, it's interesting that usually it's the LAD. As you can see, second, it's the right, and the circumflex is a distant third as far as which vessel's involved. If you take that 80% incidence of finding a culprit, and 93% of the time that culprit's occluded, and multiply them together, you can see that you get 3 out of 4 patients who present post-arrest with ST elevation have an acutely occluded culprit that wants and needs to be opened immediately. Well, here's an example. 69-year-old fellow, bachelor, lived across the street from the fire station, was not feeling well, had chest pain, walked across to get help, and promptly collapsed in front of the firefighters. Fairly convenient. They brought out their AED, he was in VF, they shocked him, as you can see, a number of times, and finally got back a blood pressure and a pulse. This was his 12-lead ECG. It's such impressive ST elevation, you might mistake this for a wide complex rhythm. But in fact, it's an inferior STEMI with 2/3 AVF and reciprocal changes in the lateral leads. This was his first picture of his right coronary. And you can see that he has a little acute marginal branch, but in that mid-vessel, it's acutely occluded. The distal right and the posterior descending are not seen. Here's the way it looked just seconds later when the wire went through, still some clot. Here's how it looked after stenting. And he did actually very well. It took him a while to wake up, mostly because of the difficulty in resuscitating him. But he awoke at day 9 and was completely normal. I see him in clinic now. He is absolutely 100% intact neurologically. Well, those are the easy ones. And again, what I say to the interventional community is you better have a good reason not to do those patients, since it's a class 1 recommendation. But what about those without ST elevation? This is the more difficult group. Here's an example of a young man who had VF cardiac arrest after swimming in his usual workout. If you look carefully, he's got a little bit of J-point depression. But frankly, if this was a treadmill test, you'd call this negative. There's no obvious ST elevation. This was his first angiogram, and it's a little difficult to see, but that's why I put the arrow there. That shows his left anterior descending cut off right off the left main with no sign of an anterior STEMI on his 12 lead. I've been asked 100 times why that is. I don't know. Why does it not show up post-arrest? We aren't sure, but we are sure that sometimes it does not, and that it is not a dependable marker as it might be in people without cardiac arrest for an acute vessel occlusion. Here's his LAD restored within a few minutes. His echo certainly showed the temporary stunning, the global stunning that occurs with cardiac arrest, recovered completely within 5 weeks. And this is Brian Duffield's picture on the front cover of Newsweek back in 2007. Well, within 16 months, Brian was back swimming competitively. Here he is coming out of the San Diego surf, having swam in the rough water swim that they have annually. But this is my favorite picture of Brian. This is the very day of his cardiac arrest 10 years later, when Brian and I had the privilege of speaking in Alaska together, took a day off and went fly fishing together. Well, if you take this group of patients to the cath lab, what do you find this time? Again, the vast majority are these kind of folks. 3/4 of the resuscitated do not have ST elevation apparent on their 12 lead. 1/3 of them, however, have a culprit identified at cath. And 69 or 70% of the time, that culprit is acutely occluded. Well, let's do the math again. I'm going to skip that slide. If you take that 1/3 of the patients have a culprit, and 70% of the time that culprit's occluded, that's 1 out of 4 patients. 1 out of 4 post-arrest patients with no sign of ST elevation on their ECG have an acutely occluded vessel that caused their cardiac arrest. It's not just true in Arizona, but here's 5 studies now, added up, simple math, and it looks like 1/3 to 1/4 of them have an acutely occluded vessel. So the question that I pose to the interventional community, is that enough for you to get out of bed and come in and cath these people? Granted, 3 out of 4 will not have an acutely occluded vessel, but there's always something to learn. And I believe 1 out of 3 or 1 out of 4 is enough to come in each and every time. Well, can't we be more selective? Isn't there some way to tease out which people really need to come that don't have ST elevation? Christian Spalding, in that very first series in 1997, wrote this: the clinical history and the electrocardiographic findings, such as chest pain or ST elevation, are poor predictors of acute coronary occlusion post-arrest. They found in their series 11%. As I just showed you, that's kind of the lowest number we've seen over the last 2 decades. It looks like it's at least 30%. Well, this paper came out in 2011 suggesting that you could further judge by the EKG, besides just ST elevation, who really needed to go and who had an occluded vessel and who did not. If you follow this along, if you have ST elevation, that's a very strong sign. I agree. But if you didn't, if you had ST depression or a bundle branch, that added to the diagnostic ability of the EKG to guide you. And they felt that if you had none of those, then you didn't need to go. And as you can see, they claimed 100% sensitivity. But this little schematic has never been prospectively evaluated, except in my series of 1. This is Brian Duffield's 12-lead ECG. He would not have been taken to the cath lab according to that algorithm. And he certainly had an acutely occluded LAD that was not known until angiography. Well, we took a different approach a couple years ago and put out an algorithm about what clinical features might portend to not doing well post-arrest in the cath lab, and could we then kind of guide ourselves by looking to see who should perhaps not go. I'm not going to go through this algorithm in total, but I'll just take you down to those unfavorable features. They're not rocket science. If you closed your eyes before you saw the slide, you could have named 5 easily. Unwitnessed arrest, non-VF, no bystander CPR, a prolonged period before a pulse was restored, ongoing CPR when you get to the hospital, a low pH, a high lactate, elderly patients greater than 85, end-stage renal disease, and non-cardiac causes. But we likewise have never prospectively proven that this algorithm really works. This was simply a literature search. And in fact, I'm disturbed by the fact that, well, does it take 1? Or do you need all 10 not to go to the cath lab? We hope to answer that within this next year as we go back and look at that with our database. Well, if you're going to go to the cath lab for post-arrest resuscitated patients, when should you go? Again, I believe it's all about identifying who has a occluded vessel and salvaging myocardium as the forerunner to saving lives. That can best be done when you go early. Here's 2 ways to look at that. Infarct size obviously increases when you wait, but also the percent of salvaged myocardium is much greater when you go early. And overall, ejection fraction seems to be preserved better. As you can see, when you go within 90 minutes in this clinical series of non-cardiac arrest, that you save substantial left ventricular function than if you wait for 6 hours. So I've come to believe that the old excuse of, well, why don't you cool them tonight and we'll cath them tomorrow during normal business hours, simply won't fly. Early emergent cardiac catheterization is the key. And that's what the guidelines suggest. Once again, emergent coronary angiography is reasonable even for select patients post-arrest without ST elevation. But does it really save lives? I showed you that we have nearly 10,000 patients now, but they're all cohort before and after studies or registries. It's very consistent. Each time we get more, it simply ups the ante by 1 or 2 percentage points, but it's not proof. I understand the bias that comes with such data, and I understand that there are some who really still believe we need randomized trials. Even though I'm a believer, we've jumped into that arena. There are now 9 RCTs underway throughout the world. Here's the first 5. These are almost all pilot studies, but one here from Sweden, one from the Netherlands, mine from the US, but also with sites in Australia and Slovenia, and on and on. Each of these were not designed for large numbers, but there's 4 more already begun. Tomahawk emerged, Disco 2, the Swedish study, and Access, a trial in the US led by both Dr. Yiannopoulos and Aufderheide, that are much more powered. Look at these numbers, 550, 1,000, 1,000, and 860. We will get some randomized data in the next 4 or 5 years. The question is today, what will you do at your community? Will these patients have the benefit of being treated with knowledge of whether they have an acutely occluded vessel? Or will we wait and see how they do neurologically and maybe take them to the cath lab 2 weeks later on their way home? Well, let me switch gears a little bit from the post-arrest patients from out-of-hospital cardiac arrest and talk about cardiac arrest in the cath lab. When I first began to think about this, I thought, well, that's a good place. Got a lot of help, a lot of expertise. If you're going to have a cardiac arrest, why not do it in the cath lab? It turns out that's actually not very accurate. Let me show you this case. This was in the New England Journal a few years ago. Just look at this one still picture from their video. What do you notice? Well, there's the catheter at the top and part of the right coronary, obviously cut off. But what's that object in the middle of the picture? That's a wedding band. In order to do CPR and fix the artery at the same time, somebody's got to have their hands in the beam. Not only are their hands in the X-ray beam directly, but their head is right next to the source. Not a good position if you're doing 20 minutes of CPR. And finally, the other bad problem is that you're usually on the other side of the table. I've commandeered the right side so I can fix that artery and correct the underlying problem. So you're on the opposite side, usually leaning way over, trying to do CPR in a very abnormal position. They're not teaching that today in the mass training as the preferred technique. Well, you can guess what happens. I'm going to skip through that. But what happens is that those chest compressions are dramatically interrupted because you want to get your hands out of the beam. I want them out so I can see my wires and my balloons to fix that artery. And as best we can determine just by observations in Tucson, probably you get 1/3 of the time chest compressions during manual efforts in the cath lab for cardiac arrest. The other time you do not. What can be the answer to that is a mechanical device. And the guidelines in 2015 gave this a 2B. Possibly useful, you can try it, but you're not required to try it. But I'm intrigued that this is a special circumstance where a mechanical device can make a huge difference. The positives, there is no safety issue. You get much more consistent compressions. They each have their issues in angiography, but it's not that you have to stop for somebody's safety. It does take some time. You need to practice getting this on. I found the biggest challenge is the doggone bed sheet. Gets in the way of clicking down the two connectors. But if you know that ahead of time, you can work through that. So there are two devices that have been looked at in the cath lab, the autopulse. You can see here, as you look at the interruption during manual efforts and the very consistent compressions with small pauses for ventilation once the autopulse is on. Here's how it looks. There are tremendous electronics in that backboard. And so it is full of metal. One occasional views, here's a very steep areocranial view. You can see everything you need. You can see the wire. You can see the two dots on each end of that balloon. Here's the balloon inflated. No question, that's a good view. You can work in that. But here's another one. I challenge you to even find the wire. It's at the bottom right corner. It's not that thick wire going across. That's an EKG lead. There's too many electronics for an AP view. But generally, we use cranial and caudal views anyway for this kind of work. Here's the autopulse, and that little trick slide shows you that you can buy it with a carbon backboard that's radiolucent. Now, obviously, the column gets in the way. You can't put your X-ray machine above it. But again, you can go around it and get the cranial and caudal views that you need. Here's examples of that. One of the problems is in America, it's becoming an issue of how big the Lucas is. I keep telling the company, you need to make the American version. Well, I found it in Tokyo last year. Even for the largest American, we can get them in this one. Here's a case of sudden cardiac arrest due to left main occlusion with very bad distal disease before the occlusion. And you can see that the heart's just not working, the dye's not leaving the aorta. It fills the coronaries a little, but this patient is not going to do well with just CPR. You must fix the underlying problem or the long-term result is not going to be good. Here's that same patient now. The LAD was the problem, the left main LAD. Actually, once we have reasonable flow, look how good the flow is in the circumflex and its obtuse marginal branches. Now, granted, you know, this is a moving target. This is not for the weak-kneed or the novice, but you can get a wire down that artery. You can get a balloon down. I personally turn it off just before I place the stent to make sure I got it in the right spot. and as soon as the balloon is up, I turn the Lucas back on. Well, I was part of a series, mostly from Europe, but of 43 patients, all suffering cardiac arrest in the cath lab. First thing you should ask yourself was, what's your denominator? I'm not going to go into that. We had 43 cases. 5 of them had spontaneous rupture with their acute STEMI. Those patients are not salvageable. So if you take those out and look at the 38 who did not have rupture, you'll see at the bottom right that 29 or 30% survived that event neurologically intact. If you interrupt manual compressions 2/3 of the time, and it takes you 30 minutes to fix that vessel, that patient will not leave the hospital neurologically intact. So this is a 30% success rate in a population that's doomed. Interestingly, VF does the best, but look who else does pretty well, those with asystole. Unfortunately, the most common rhythm is PEA, and they didn't do as well. I think it's because PEA at that moment is a marker for really, really bad myocardial function. Well, what about left ventricular assist devices in the cath lab? As an interventional cardiologist, we've gone through a revolution in the last 5 years. We're doing much more high-risk caseload, and we're using a lot of Impella, which is a percutaneous left ventricular assist device. It's a pigtail catheter with a rotary pump inside, so it actually unloads the sick left ventricle and helps you go ahead and dilate the left main, including all flow to the left side, while you still support that left ventricle and it doesn't dilate and fail. But many people have taken that experience and said, well, you know, it is a pump. If I get into real trouble and have a cardiac arrest, I'll be okay. I have a pump in. But nobody actually had tested that hypothesis until we got around to it in our translational laboratory. Here's how it looks. Again, that's manual CPR attempt in the cath lab. Notice the one thing is you can't fix that artery while you have that beautiful column out of the way and everything's just fine. There's no x-ray machine there. It's a lot tighter when the x-ray is in place. And on the other side is this Impella left ventricular assist device already inserted into the LV, as it often is in any high-risk angioplasty. Well, we decided to compare these 3 techniques. And in fact, then even did a 4th group and combined the 2 mechanical devices. Here's what we found. For return of spontaneous circulation, this is an animal model, but it's 10 minutes of, it's 12 minutes of acute left main occlusion, complicated by VF for 16 minutes. So it's a pretty sick pig. But we can get them back. You can see 50% with manual, maybe 80% with Impella or the combo. But they don't do well with interrupted manual as far as their neurologic function 24 hours later, 0% intact. Impella or Lucas alone, separately as 2 different groups with only 1 device, about a 30% success rate. But look at what we got when we combine the 2. 60% or 56% to be exact. And I think the issue is Impella is very effective at unloading a sick heart, a left ventricle that's not pumping well. But it's not that strong of a pump, and you really need a little more assist to literally circulate the blood enough to get across the lung and refill the left atrium so you can refill the left ventricle. But when you put the 2 together, we were impressed. This looks like a winner. Because those 2 single devices look the same, they're about the same, about 30%, we combined just to see how that looked. And here you can see, again, no difference in return of spontaneous circulation, but a beautiful stepwise progression from 0 to 30 to 60 when you combine the 2 devices. Well, let's move to eCPR for a moment. What do you do when it's not working? You know, Albert Einstein is credited with that phrase, doing the same thing persistently when it doesn't work is the definition of insanity. He actually didn't come up with that. I looked that up one day, but It was from Alcoholics Anonymous, which may be an even more potent message, frankly. But this happens to us, not every time, but clearly we have patients in the field not responding to standard treatments who are too good to just stop and let die. So that's where this whole concept of using a mechanical device to transport that patient to where further treatment is available, i.e. the hospital, and starting them on cardiac support, i.e. ECMO. There's 2 clinical trials. They're both small little series. This was the first, Dion Stubb and Stephen Bernard in Australia. They did this CHEER trial. 11 patients out of hospital, 15 patients in. My math says that's a total of 26. It's not many. But they had some remarkable results. I'm going to just concentrate on the out of hospital, those 11. The end of the day, 5 of those 11 survived. And again, this is usually a group where the survival is 0%. Not many, small series, but a feasibility study that shows this could be done. And of those who survived, those 5, in fact, all of those 5 were neurologically intact. The 14 of 14 includes the inpatient ones as well. But everybody who survived was intact. Well, we've heard all week long about Dimitri and his work, and I think rightly so. In my opinion, this is one of the most important articles in the last 18 months. They did a similar project, slightly different. First group used an autopulse. This one used Lucas. Doesn't matter. They were very careful about who they would do ECMO for. You had to be a certain age. You had to be within 30 minutes of the cath lab. They've actually loosened that as they've got more experience. But this is their first report, 18 patients. One of the most important parts was that don't be in a hurry to take away their assist device after you resuscitate them. Look at the ejection fractions for the first 24 hours, the blue bar. The second 24 hours, the gray bar, 15 to 10%. If you pull that device off just because you got them back, you stand the risk of losing them by cardiogenic shock. But notice what happens over day 3, 4, and 5. Their myocardium recovers fully. This we knew from 10 years ago in our pig work. This is a transient stunning, but it's global and it's lethal without support. But it will get better if you support these patients. It's exactly what they found. Well, here's their outcomes. They also got everybody resuscitated, almost, one loss. 10 out of 18, 54% survived a discharge, and of those 10 who survived, 9 were intact neurologically. Well, put those together. It's a whole 29 patients with out-of-hospital arrest who went on to mechanical devices for transport to the hospital for ECMO, and 52%, 15 of 29, survived. And of those who survived, 14 of 15, 93%, were neurologically intact. He's actually updated this. This was our personal conversation a few years ago. Just look at the 45 patients, still 51%, 91% neurologically intact. Now they have over 100, and it holds up. I think the survival is maybe 46%. It's going to hang right around 45 to 50, but the neurologically intactness is still in the 90s. If you get them back, their brain recovers. Well, there's actually one randomized trial underway in Europe. These are very tough to do. I think Tom and Dimitri have aspirations to do one in the US. We'll see. Well, let me end with just a few comments about what we witnessed last night. I thought those 2 videos that Vinay showed were really spot on. If you remember, he showed first, about 15 years ago, a highly recognized college student, looked to be like the first in the NBA draft coming up, collapsed on the court, and nobody did anything for minutes. They even had an AED, as he pointed out, but they were not willing to apply it. And he died. Then they showed one just from last week from South Carolina State, where the young man had just come off the court sat on the bench and collapsed. And they did not wait. They immediately started chest compression only CPR. They immediately got their defibrillator. They weren't afraid to take his shirt off and apply the pads and shock him. And he is alive today, and as we heard last night, recovering. But it brings to home a very important point. This is a special subgroup, young athletic individuals who have cardiac arrest. And unfortunately, they don't always do as well as you would suspect they should. These are the lists of the most common causes. We're all aware of hypertrophic myopathies. But the second on the list is coronary anomalies. Happens 2.5 times more common in athletes than non-athletes, and you can see the frequency there for both college and high school, about 1 in 25,000. A little more in military recruits for some reason. These are the most common sports associated with this tragedy. Basketball, number 1. Soccer, number 2. And baseball because of the Komodo. It's interesting, Komodo is where you get hit by the ball, you get enough electrical current, albeit as small as it is, hits you just right on your vulnerable side of your T wave and you fibrillate. Almost never happens in the pros because they throw hard enough that you're outside the range where this phenomenon occurs. But it's commonplace in Little League and Pony League, the 12 to 16-year-olds, and then hockey. The problem is recognizing this. We're not expecting a young person to collapse. It's always thought to be a seizure or some other silliness, and often they do seize, but they seize because they're in VF and have a anoxic brain injury. They need an extensive workup if they're lucky enough to survive, including all of those tests, in my opinion. Well, let me show you just 2 cases to bring this home in a real way. I was asked a few years ago by the Attorney General of Arizona to look at a case. You can imagine this was not going well. Some family was very disappointed and were suing for $20 million. I asked him, I'll tell you what. First I said, I have a conflict. This was at the other university in Arizona, our state rival. He didn't think that was too funny. And then I said, well, I'm willing to do it, but I just want 0.1% of the money that I save you. He didn't think that was funny either. But it was a tragic but interesting case. 21-year-old, good high school football player, but not good enough to be recruited. Goes to the other university, decides he'll play intramural ball and walk on and get his rightful share of glory. Unfortunately, collapse on the intramural field. He's gasping. Everybody thought he had asthma. Then he seized, and everybody thought, oh, he must have epilepsy. Get a towel to put into his mouth so he doesn't bite his tongue. And unfortunately, it took them, as you can see, 10 minutes to figure out that this was more than just asthma or a seizure. An AED was at the facility. They found it. It had not been maintained. The battery didn't work. Time to open the bank, really. Finally, EMS arrived. By this point, he was transported with ongoing manual CPR in the back of an ambulance, which is not very effective, and could not be resuscitated. When he went to post, this is what this is what the pathologist, the medical examiner wrote in another city. No hypertrophic or dilated cardiomyopathy. Good. But no actual descriptions of the coronary except this quote. It's peculiar there are 2 ostial openings in the right coronary cusp of the aorta. No mention of whether there's a left main opening or not. Well, this young man almost certainly had what is known to be a deadly congenital anomaly, where the left main coronary cusp comes off the right and has to go between the aorta and the pulmonary artery. 2 reasons this doesn't work. It gets pinched, and the acute angle makes this a very slit-like opening. And I don't know how he survived high school football with no troubles, but that day he didn't do well and became ischemic and had VF arrest. Well, one more. 27-year-old former Marine. This fellow has obviously exercised in the past. Wanted to be a firefighter with Tucson Fire. Was training and literally carrying the 70-kilo dummy up the stairs, one of the exercises they make him do. gets to the top of the platform and collapses. Everybody thinks it's a joke. Get up, come on, let's go. He doesn't get up. Finally, somebody runs up the steps and finds he has no pulse and he's unresponsive. They run back down, go to a truck, get one of the AEDs off the truck and go back up. He's in VF, as you can see, he gets shocked once and has returned to spontaneous circulation. He has a blood pressure, but he's comatose upon arrival. His blood gas isn't too bad. His lactate is right on the edge at 7. Had CT, had a big scalp laceration, was negative. Here's his EKG. Absolutely normal, not even sinus tachycardia. So the real question is, what happened to him? And is there any value of going to the cath lab for such a young person that almost certainly doesn't have bad atherosclerotic disease? Well, I decided to take him anyway, because I didn't know. And here's the first shot. Let me explain this. This is a left catheter, and it's in the left coronary cusp, but I couldn't find the left main. So I shot just a non-selective view. And as you can see on that cusp, there's no opening, there's no left main. But he's alive, or he was alive. Here's the most important view. This is the right coronary, and there's a tiny branch that gives all of the blood flow over to his left system. His left main during development, embryology 101, never rotated and hooked into his aorta. So all of his left-sided blood flow was through that tiny little branch of the right. I'm going to just show you how that actually looks. So he had bypass. That's what the Lima graft is to his LAD. But look at the space between his cusp and where the left main starts. There's a full centimeter, and it never hooked in. Well, he got bypassed, as you can see, and he's done exquisitely well since. Well, I used those two cases to show that there's another reason to go to the cath lab post-cardiac arrest, and that is you just never know what you're going to find. But you always find something that's very helpful. Thank you very much. It's been a real pleasure.